Namaste everyone. Welcome to the another lecture. So in this lecture today we are going to complete the hypertension topic. So the remaining aspects of hypertension we are going to discuss in the today's class. Now yesterday we have studied till pathophysiology. In continuation to that, today we are going to discuss about the clinical feature of hypertension. The clinical features of hypertension are very minor. We do not have any specific disease specific clinical feature that can tell us that the person is suffering from hypertension. As we have discussed in yesterday's class, hypertension is also known as silent killer because we don't have any particular symptoms that will allow us to diagnose the condition by just seeing the sign and symptom. However, if the blood pressure is increased abnormally, then there can be some alarming signs or symptoms that can be noted in the day-to-day life. So these are headache. The person who is having high BP, he may experience headache, especially the headache will be like overall headache. It's like a generalized headache, and he or she may experience some nausea, anxiety. There can be epistaxis. If BP is so high, epistaxis is nothing but the nasal bleeding because the small microvascular structures may get rupture in the nasal region, which may lead to the epistaxis. Then the another symptoms may be lightheadedness. Similarly, there can be breathing difficulty in some people. So person may complain of palpitation. What is this? Palpitation means person if he is there in the rest condition, at that time he or she will be aware of their own heartbeat. He or she will be able to hear their own heartbeat. So that condition is known as palpitation, and giddiness may be complained by the patient. So these are some clinical features of hypertension. However, these are not so common. As we have already discussed, it is known as silent killer. Right? Now we will see the another segment, that is diagnosis, how to diagnose BP. Now I think from yesterday's class you all have come to conclusion that to diagnose the blood pressure, one should measure their blood pressure. So that is the best way how we can diagnose the blood pressure, if the person is having high blood pressure or not. So what we have to do means we have to measure the blood pressure exactly following the standard operating procedure. There are some standard procedure to measure the blood pressure. The person should be in the sitting position, and the sphygmomanometer device should be kept at the height of heart, and we have to follow the standard procedure. The cuff should be properly tied. A person should be out of anxiety. He should be counseled that we are going to take BP, so no need to be nervous and all. So all those things we have to discuss, and then we have to go for measurement of BP. And once if BP is high and one measurement, we have to call him again after a week or two. Then we have to measure the BP twice. Similarly for thrice time. If in 3 regular visits we are getting blood pressure is high, then we can diagnose the condition as a high blood pressure. So one time we should not make judgment that person is having hypertension, because BP may be increased due to some other reasons also, as it is a physiological parameters. We all know that. Then we can check for the associated parameters like glucose profile, lipid profile, and electrolyte profile, including the hormone profile like thyroid and all, because if there is a hyperthyroidism, metabolic activity in our body will increase to fulfill the demand of nutrition, oxygen, and glucose. Our heart has to work more. In that way our blood pressure may get increased. Right? So these will give us idea whether there are any other comorbidities or not, that can be checked. And complete and detailed history plays an important role, whether in family someone is having history of blood pressure or not, or what is the lifestyle he is following, whether he is having sedentary lifestyle, then BMI, obesity, all those things will give us a brief idea if person is at higher risk or not. So that can allow us to diagnose the blood pressure. So these are some basic tests to diagnose the blood pressure. Out of that, the most important is the measurement of blood pressure. So this has to be kept in the mind. Now we will go to the management. So now this management is little tricky, and it requires a great effort, a lifelong effort is required. So here I have made summary of some non-pharmacological measures and some pharmacological measures. So I will start with the non-pharmacological measures. So here our aim is to control the blood pressure in the normal limits. So that is our aim. So in pursuit of that, now we will see what type of measures can be done. I will just go quickly through them. Now first is the weight loss. If a person is overweight or obese, right, the BMI should be in the normal range. That should be our goal. Now here this is a rough estimation, not very precisely, but majority of people are reporting this. If we are reducing the weight by 1 kg, it may change the systolic blood pressure by 2 to 5 mm of Hg. So if a person is losing 1 kg of weight, it will significantly affect the systolic blood pressure. So while losing body weight, we have to be very cautious that adipose tissue, or simple term, fat should be reduced rather than muscle mass. So proper diet should be there during the weight loss. We should not go to the crash diet or deficiency of nutrition. Such weight loss will come back as a rebound effect. That should not be the case during the weight loss. So it should be done with the balance of exercise and with the conscious diet. Some common exercise that a person can do during the weight loss are walking, jogging, cycling most of the day, and the diet should be taken care. So all these come under the aerobic type of exercise only. Now the another concept is the DASH diet. What is DASH diet means? A dietary approach to stop the hypertension. So this is a whole new concept. I will not go into the detail of DASH diet, but here what should be the component of DASH diet means there are higher amounts of fruits, green leafy vegetables and other vegetables, then whole grains rather than the grain derivatives, contains little less amount of fat and carbs. If fat is also there, means we are taking a good quality of fat like dairy, cheese and all, rather than just the trans fats. So this can reduce, adopting the DASH diet can reduce the systolic blood pressure from 3 to 11 mm of Hg. This I have compiled from various sources. In different sources, different values were there. That's why I kept them in the range. Then another important is the reduction of sodium content. So what should be our daily limit to the sodium content if a person is having hypertension? From 1000 to 1500 mg per day. That is 1 gram to 1.5 gram. So it will roughly reduce 2 to 6 mm of Hg in the systolic blood pressure. So it simply means that we need not to take any additional salt in some fruit, salad, sarbat or some other drinks. So no need to sprinkle the salt above the fruits or any other drinks. So that will largely show the effect. Then increase the potassium. Potassium intake can be increased up to 3.5 gram to 5 gram in a day. So this potassium intake should be from the diet rather than taking any medical supplements. This also helps in reducing blood pressure by 2 to 5 mm of Hg. So wherever there is a role of sodium in the action potential, in place of that potassium will go and do the work in the action potential, so that person will not have any neurological difficulties or action potential related issues. Then what type of exercise, right? There is a brief summary. Aerobic exercise means where if we are doing exercise we are not having breathlessness. That is a common way how we can identify which is aerobic or which is the anaerobic exercise. Then 90 to 150 minutes per week. एक दिन में 1.5 घंटे से लेके 2.5 घंटे तक हमको एक्सरसाइज करना है. Some example of aerobic like brisk walking, dancing, swimming, all these are the aerobic exercises. It will help us in reducing 2 to 8 mm of Hg. Similarly, some dynamic resistance exercise can be done. So these dynamic resistance exercise like dumbbell, squat, push-ups, all those where we require little energy, those are dynamic resistance exercise. So this also needs to be done from 1.5 hours to 2.5 hours in a week. It will also help in reducing the blood pressure. So how this has to be done is at least 6 different types of exercise, 3 sets of each exercise, and in one set there can be 10 repetitions. Now I will take example of push-up. So push-up is one exercise out of 6 exercise. So total 3 set of push-ups should be done, and one set of push-ups should contain 10 repetitions. In that way we can do any 6 type of exercise in the dynamic resistance exercise which will help us in reducing the blood pressure. Similarly, the isometric resistance exercise. So in this exercise, some exercise like hand grip, what we have to do is we have to repeat the cycle of 4 up to 2 minutes. Okay. So then we have to take 1 minute rest in between. So it will help in great reduction of systolic blood pressure. So it has to be done like 3 sessions in a week. Example, plank, we all know plank static. So plank we should try for 4 minutes, right? 4 times for at least 2 minutes. And after doing for once, we have to take 1 minute gap. Then we have to do it for another time. Then 1 minute gap, then another time, then 1 minute gap, then another time, then 1 minute gap. Like this, 3 days we have to do. Then some other examples like static yoga, squat, all those things we can do. It is again greatly reducing the systolic blood pressure. So this can be adopted. So what type of exercise is fit for what type of person? According to age, according to the conditions like pregnancy and all, we can recommend these type of exercises. Then if a person is consuming alcohol and he is a smoker or she is a smoker, then if they are able to reduce it or quit it, it will substantially reduce the systolic blood pressure by 3 to 4 mm of Hg. Similarly, stress-free sessions and meditations greatly help in reducing the blood pressure. Similarly, fresh air walk at the morning time, then spending time in the pleasure activities. Every person are having their hobbies. So if they are spending time there, so it is thought to reduce the blood pressure. Spend time with pets and animals. If we are having some pets and animal at house, and if it is available at our house, then we can go for that. It will reduce our stress and ultimately reduce the blood pressure. Similarly, mindful eating, not the unwanted eating, especially overeating should be reduced. So mindful eating, whatever is required, how much is required and what type of food is required, whether it is required or not, then only we have to eat. That is called mindful eating. So this I have taken from the American College of Cardiology and American Heart Association. So this is the brief information about non-pharmacological management, and this non-pharmacological management is largely used in the patient counseling section also. So please go through this thing. I will attach the note in the Telegram. Soon I am going to update the Telegram by another week. Now we will see the another important concept, important component for managing the hypertension, that is the pharmacological management. So quickly I will be explaining the classes of the drugs and how they are going to work, right? So our first class comes diuretics. So examples are thiazides and thiazide-like diuretics. Similarly, we are having other like loop diuretics, potassium sparing diuretics, then carbonic anhydrase inhibitor. So what these drugs will do, they will go into the different channels, right? Their mechanism differs from each other, and what they will do, ultimately they will enhance the sodium excretion. So along with the sodium, water will also go, and if water will also go from our body, means ultimately there is a reduction of cardiac output. So now here sodium is going, along with that water is also going means volume is coming down, means cardiac output is coming down. And please remember this particular formula, BP is equal to CO into PR. Now if CO is reducing means BP is reducing. So in this way it is helping in managing the blood pressure. Our second is the beta adrenergic blockers. And here some examples, some other subclasses are beta 1 blockers like metoprolol, atenolol. Then there are non-selective which will affect beta alpha or sometimes beta 1, beta 2. So these are propranolol. Then some drugs are there which will affect alpha and beta subtype of receptors, adrenergic receptor. They are labetalol and carvedilol. What this basically do means, so if this is our heart, in our heart we are having certain receptors called beta receptor. If this is getting activated, our heart will contract faster. Now these inhibitors will inhibit the beta receptor. This contraction will become slow. Once this contraction will become slow, CO will also become low. Then due to this, BP will also become low. So this is how they are working. Then another is the ACE inhibitor. ACE means angiotensin converting enzyme. Angiotensin converting enzyme. Now I'll just show you the yesterday's RAS mechanism cycle. If this was a RAS mechanism cycle, so here what we have told means this angiotensin 1 is converted to 2 by this ACE enzyme. Now here what we are doing, we are blocking this enzyme. So angiotensin 1 is not converting to angiotensin 2. So all this BP increment is a result of angiotensin 2. Now if this is not available, only one is available, this don't have this activity. It does not have this activity. Due to that, what is happening? Our blood pressure is not getting improved. So that we have to understand. This is how ACE inhibitors are working and they are reducing the blood pressure. Now another is the calcium channel blocker. Calcium channel blocker. Now in our heart, there are specialized channel called calcium channels. So in calcium channel also there are various subcategories. So it basically act on the L type. There are various types of cycle. So in L type of cycle cells, it will receptors, it will go and it will bind. What happen means, if this is cell, whenever calcium is influxing, always remember in your life, whenever calcium is influxing in any cell, this cell will contract, right? So in cardiac cell also, if calcium will go means this cardiac cell will contract in a higher rate with higher depth. So if we are blocking these calcium channels, calcium will not able to enter into the heart. It will relax the contraction, which will reduce the cardiac output and reduce the BP. In addition to that, these calcium channel blockers in blood vessels also we are having L type of calcium channels. Now it will not able to go in the blood vessels also. So whatever the contraction is there in the blood vessels also, it will also not happen. It will inhibit the contraction. Due to that, these blood vessels will also not get constricted. Rather they will dilated. Due to that, again PR will also get reduced and they will effectively reduce the BP. They are very potent drug and widely used drug also. That's why, because they are working in heart and blood vessels both. Another is the adrenergic inhibitors. These adrenergic inhibitors, they are directly going to the CNS. Yesterday we have discussed in this mechanism, our CNS, medulla oblongata. This figure we have discussed. Medulla oblongata is telling beta receptor to work more. It is telling kidney to initiate the RAS mechanism. Now we are going into the central system and we are influencing here, and now this is not giving further message to heart and kidney to increase the BP. So in that way our BP will get reduced. Then our another category is the angiotensin 2 receptor blocker. Again we will just go through the RAS cycle. Here this angiotensin 2, how it will work means this angiotensin will go to the angiotensin 2 receptors are there in the blood vessels. So it is going there in the blood vessels and showing its activity. Now those receptors will get blocked. Angiotensin is there, but their receptor is not there, means these all activity will be again stopped. So for effective control, ACE and ARB can be sometime combined with each other so that there will be the better action, right? So that is how ARB are working. Then some another classes are renin inhibitors. So this RAS cycle, it all story starts with the renin production, right? Here we have seen renin production. Sometimes we can block this so that this entire story will not happen. Some others are vasodilators. Now from name only we could understand, if we are giving some vasodilator means this blood vessel is there, they will dilate the blood vessels. Obviously peripheral resistance will come down and BP will reduce, right? So this is the ultimate master formula for hypertension. Now another is the endothelin receptor antagonist. So we have yesterday also discussed, nitrous oxide will reduce and endothelin will increase in the hypertension. If we are able to antagonize this endothelin, it will help in reduction of blood pressure. So this is all about the mechanism of all these antihypertensive drugs. Now how to manage this hypertension, right? So this is a algorithm how we are going to manage the hypertension. Now if a person is having pure hypertension, there are no compelling indication. No compelling indication matlab he is not having any comorbidity, no any other conditions are there. If his blood pressure is in stage 1, we should go with either diuretics as we have discussed there, ACE inhibitor, ARB, CCB. We can give as a monotherapy. Sometime if it is required, we can give a combination therapy of 2 compounds. But if it is BP is in stage 2, then we will definitely go with the combination of 2 drug therapy. So which drug we are going to combine? All these drugs we can combine extensively, but diuretics is a common everywhere. So that is very easy to manage that. Now question comes, if a person is having the morbidity or there is a compelling indication, so at that time what to do? Now here our aim little varies. Our aim is to increase the survivability. So if this hypertension is progressing, means we have to slow down its progression. So reduce the side effects and increase the effectiveness of the therapy. In that way we have to manage the therapy. Now if a person is having asthma, for example, he is having hypertension and he is having asthma also, in that condition we should always opt for CCB, and if CCB are not available, then alpha blockers angiotensin receptor blockers and ACE inhibitors we can give. Very red flag for beta blocker, because this beta blocker will constrict the beta 2 blocker also, beta 2 receptor also. These beta 2 receptors are there in lungs. So in asthma already he is not able to breathe properly. If these lungs will get constricted, the air will not enter into the lungs. Person may have a breathing difficulty or sometimes respiratory distress and respiratory failure also. So these should be avoided. Similarly, another condition, very common condition, hypertension with diabetes. Here also, alpha blocker, ARB, diuretics and ACE inhibitor should be preferred. We should avoid the beta blocker. Why means these beta blockers will again act in the lungs and various other organ system also, which will harm the person. Similarly, the another is the dyslipidemia. So in dyslipidemia also beta blockers should be avoided. So alpha blocker, CCB, diuretics and ARB should be our drug of choice. Then similarly we will see some another conditions like pregnancy. Pregnancy, almost all the antihypertensive drug which are working in the various system, RAS mechanism and directly adrenergic drug and all are having some sorts of unwanted effect. So here we will go with the safe drug like alpha methyl dopa, clonidine, hydralazine. So all those centrally acting drug we will prefer in pregnancy. They are relatively safe than other drugs. If person is very old, then we should go with CCB, diuretics and ARBs. Similarly, in an old person only, if a person is having benign prostate hypertrophy along with hypertension, then we should always opt for alpha blocker. This will relieve the smooth muscle in the prostate region also. Then ARBs, ACE inhibitors, CCB and diuretics. Similarly, if a person is having hypertension and he is having other coronary heart diseases also, like dyslipidemia, then angina pectoris and all, then we should go with the beta blocker as a drug of choice, then CCB and ACE inhibitor. Similarly, if a person is having congestive heart failure also means, then ACE inhibitor and beta blockers are drug of choice. If a person is having isolated hypertension, means either systolic is increased or diastolic is only increased, that time diuretics are the drug of choice. Sometimes we can even give the calcium channel blockers. So hope you have understood this concept. Now we will see some additional concept in the management of diabetes in the compelling indication. Now if a person is having resistant hypertension, right? Now first let's understand what is resistant hypertension. Resistant hypertension means it's uncontrolled BP. Despite 3 drugs, we are using the combination of 3 drugs. We are giving the combination therapy of 3 drugs. Still BP is not in control. So at that time we have to add the spironolactone. Please remember this. This is very important for Viva point of view also and in a practical exam point of view also. This is a drug of choice in resistant hypertension. We should add the spironolactone and sometime if it is available we can go with the amiloride also. Then there is another important concept called malignant hypertension. So malignancy means having the issue in the other region, as cancer is also there, right? Malignant. So we can understand by that name only. It's a severe type of hypertension where BP is systolic more than 180, diastolic more than 120, and this is important. Plus TOR, that is target organ damage, means there papilloedema is there. Papilloedema is the retinopathy is there, means there is a edema in the eye. So this condition is known as papilloedema. If there is a papilloedema or any other target organ damage along with the severe hypertension, we will tell that hypertension as a malignant hypertension. And here our drug of choice is sodium nitroprusside in the IV route. Similarly, labetalol IV also we can give. Then if there is a hypertensive emergency, now let's understand the difference of hypertensive emergency. So sometimes people will say it as accelerated hypertension also, but anyway there are little fine differences there, but clinically we cannot differentiate them because management rely in the same way. BP is more than 180 and 120. There is no target organ damage, but target organ damage is ongoing, means it is in the process but not reached to the malignant stage. Yes, but target organ damage has initiated. This is called hypertensive emergency or accelerated hypertension. So treatment remain almost same like malignant hypertension. Then another condition is called hypertensive urgency. So this is emergency, this is urgency. We have to understand. This is severe hypertension without TOR. TOR नहीं है. Severe hypertension तो है 180, 120 है. TOR भी नहीं है and progression भी अभी तक नहीं हुआ है. So this is little less severe. So here we can go with the oral drugs also, captopril and amlodipine. When we can go with the nitroprusside also for sudden control, then we will manage this by giving these drugs. Then There is one another condition called pregnancy-induced hypertension. So sometimes people will tell it as a gestational hypertension also. So hypertension starts after 20 weeks of pregnancy, after gestation. So again, I have mentioned in the last there only, pregnancy means we should go with the centrally acting drug like labetalol, methyl dopa, and hydralazine. If not available, then only nifedipine. Then there is another condition called gestational preeclampsia. Preeclampsia means there is a hypertension, but there is a proteinuria also. Proteinuria also, there is a kidney injury. So again, drug of choice is labetalol along with the MgSO4 because it will prevent the seizure. If in preeclampsia there is a seizure, this is called eclampsia. This eclampsia is very dangerous situation which will lead to the stillbirth. Fetal may get the suffocation and choking and end up their life. So in that condition we should add magnesium sulfate also so that it will prevent the seizure by stabilizing the neuronal activity. So this is how we should manage the gestational preeclampsia. Then hypertension, diabetes, I think this is a repetition we have already discussed. Anyway, ACE and ARB are drug of choice. Then hypertension in CKD, we should go with the ACE inhibitor and ARBs. Then hypertension along with the stroke, stroke is again the complication of hypertension. So ACE inhibitor and thiazide diuretics are drug of choice. Then there is something called white coat syndrome. During my examination, during my Pharm D, so external asked me what is white coat syndrome. I was unable to answer at that time, but in interview also sometime it may appear कि white coat syndrome or white coat hypertension. There is no hypertension actually, but people will get nervous and anxiety during their hospital visits when they are seeing doctors or any healthcare. Due to that nervousness, their BP will be high. That condition is known as white coat syndrome. So here actually no need to give any medicine. We can just educate them that this is the normal. They should be calm. So no need to go with any pharmacological drugs. Then there is something called marked hypertension. Means clinical hypertension nahi hai usko resting condition mein, but when he is ambulatory condition, the BP will increase. In such way, we should prefer CCB. Then there is something called labile hypertension. This is stress mediated hypertension. It will keep on fluctuating. Stress badhega, BP badhega. Stress nahi hai to BP nahi hai. This is called labile hypertension. So in this condition, we should opt the beta blockers, right? So up to here we have seen what type of hypertension, what type of drug should be given. But now how this drug should be given, what should be dose of that drug, mechanism also we have seen, and what are the possible adverse drug reaction. Quickly we will go through that. I have given 1, 2 example for your better understanding and remembering in your examination, so that it will be easy for you. Angiotensin converting enzyme inhibitors, example enalapril 5 to 20 mg per day. We can divide it into 1 to 2 dose. So ramipril also 2.5 to 10 mg per day. So it is having one significant ADR called dry cough. Always remember this. This is a serious ADR along with this, we have to remember that. Similarly, ARB, some examples are losartan 25 to 100 mg per day. I have made all dosage in the per day so that you can remember it for the exam point of view. Now telmisartan 20 to 80 mg per day. So what is the ADR of losartan? Is a dizziness, and telmisartan hypertension. So one major ADR I have added here. I have not added the list so that it will not create any confusion in your mind, especially for exam point of view. Now CCB, we will see some example. Amlodipine, very commonly used, 5 to 10 mg in a day we can go. Nifedipine 30 to 60 mg per day. Amlodipine may lead to the ankle edema. There may be swelling in the ankle region, and ADR of nifedipine is the flushing. Flushing means blood supply बढ़ जाता है और आदमी थोड़ा red and hot फेस दिखना चालू हो जाता है. Thiazide example, hydrochlorothiazide 12.5 to 25 mg in a day. Chlorthalidone 12.5 to 25 mg per day. Both will lead to the electrolyte imbalance, hypokalemia being one of the common among them. Then beta blocker example, atenolol 25 to 100 mg per day and metoprolol 50 to 200 mg per day. So both are having the similar ADRs like bradycardia and fatigue. Person will have fatigue effect, and bradycardia means the heart rate will be slow, pulse rate will be slow. Then alpha blocker example is prazosin 1 to 10 mg per day, doxazosin 1 to 8 mg per day. So postural hypertension or dizziness are the common ADR of this class of agent. Then some centrally acting examples are clonidine 0.1 to 0.6 mg per day and methyl dopa in pregnancy we have discussed. 250 to 2000 mg per day we can give. So these both will lead to the sedation. So this is all about the drugs which are used in the management of hypertension. Now quickly let's see some fact about hypertension. So now Hypertensive crisis was condition. This is an umbrella term. Basically, all these malignant hypertension, resistant hypertension, hypertensive emergency, urgency, all this comes under one term called hypertensive crisis. So we should not mismatch that. Then some other fact we will see. Salt sensitivity is higher among Indian population. So it simply means कि we Indians should take less amount of salt. We are more sensitive to it. But उल्टा हो रहा है यहाँ पे. We are enjoying more salt in street food, in Chinese food. Everywhere we want to add salt. So this is one very important point. Then 1 mg reduction in the blood pressure will reduce the stroke risk by 2%. Very, very important. This is the importance of maintaining the blood pressure. This needs to be educated to the patient also. So this can be useful in the patient counseling session also. Then vascular changes often begin decades early. So we should take good diet and we should do regular exercise. जैसे मेरे को 30 साल की उम्र में अगर बीपी डायग्नोज हो रहा है, इसका मतलब ये है कि मेरे को सालों पहले उसका जो पैथोफिजियोलॉजी है आर्टेरियोस्क्लेरोसिस से वो चालू हो गया था. तो मैं 10 साल पहले अच्छा डाइट खाता तो आज मेरे को हाइपरटेंशन नहीं होता. ये समझना जरूरी है. देन एक्सरसाइज इज अ प्रिवेंटिव एंड क्यूरेटिव फॉर कार्डियोवैस्कुलर डिजीज. सो दिस एक्सरसाइज इज बून टू अस. इट इज अ फ्यूल फॉर आवर हार्ट. ये चाबी है हमारे हार्ट को लॉन्गेटिविटी प्रोवाइड करने के लिए. क्या? एक्सरसाइज. वी शुड टेक केयर ऑफ आवर हार्ट. इट्स आवर ड्यूटी. Now let me complete the hypertension with one quote. Hypertension is dangerous not being high but being silent. हाइपरटेंशन ज्यादा है इसलिए खतरनाक नहीं है. ये खतरनाक है क्योंकि ये साइलेंट है, कुछ बोलता नहीं है. ये बढ़ता धीरे धीरे है. इट राइजेज क्वाइटली बट कॉम्प्लिकेशंस आर वेरी लाउड. मगर जो इसके कॉम्प्लिकेशन होते हैं वो बहुत बोलते हैं. वो जेब भी खाली कराते हैं और रिस्क भी बहुत बढ़ाते हैं और क्वालिटी ऑफ लाइफ को भी कम करते हैं. नाउ जाते जाते हम आपको एक एडिशनल बोनस देके जाएंगे विच विल बी वेरी हेल्पफुल इन योर क्लिनिकल राउंड्स. देयर इज समथिंग कॉल्ड पल्मोनरी हाइपरटेंशन एंड पोर्टल हाइपरटेंशन. वेरी कॉमनली वी आर एनकाउंटरिंग देम इन द हॉस्पिटल विजिट. Pulmonary hypertension is a serious and chronic hypertension, so which is characterized by increase in BP in the arteries of lungs. This pressure will rise above more than 25 mm of Hg. जो अपना मेन आर्टरीज है ना, वहां पे अपना 140 सिस्टोलिक और 90 डायस्टोलिक था. इन दी लंग रीजन due to the resistance it is decreased and this artery bed is fine diluted. तो यहाँ पे BP अगर 25 mm ऑफ Hg से ज्यादा हो रहा है तो उसको हम बोलते हैं पल्मोनरी हाइपरटेंशन. इसकी वजह से बाद में कार्डियक प्रॉब्लम्स हो सकते हैं. देयर आर सम कंडीशंस लाइक कॉरपल्मोनेल एज अ कॉम्प्लिकेशन ऑफ दिस. कॉरपल्मोनेल हो सकता है या राइट हार्ट फेलियर हो सकता है. तो उसको प्रिवेंट करने के लिए हमको इसको मैनेज करना जरूरी है. जहां पे हम जनरली डायरेटिक्स को बहुत ज्यादा यूज करते हैं वो पल्मोनरी हाइपरटेंशन को मैनेज करने में. देन अनदर point you will be frequently seeing in the hospital is the portal hypertension. So this portal hypertension means increase in blood pressure of the portal venous system. हमारा portal venous system है लिवर में है. वहां पे अगर 10 mm of Hg से ज्यादा ब्लड प्रेशर बढ़ जाता है तो उसकी वजह से वहां पे जो ब्लीडिंग होने का रिस्क है वो भी बहुत ज्यादा बढ़ जाता है, जिसको हम वेरिसियल ब्लीडिंग बोलते हैं. तो इसको कंट्रोल करना भी जरूरी है. जैसे लिवर डिसऑर्डर्स होते हैं, अपना अल्कोहलिक लिवर डिसऑर्डर हो गया, हेपेटाइटिस हो गया या फिर लिवर फेलियर हो गया, वो कंडीशन में पोर्टल हाइपरटेंशन बहुत बड़ा हुआ दिखता है. तो इसको मैनेज करना भी जरूरी है. सो हैविंग सेड दैट, सो वी विल एंड आवर lecture on hypertension here only. If you are having any questions, any suggestions, any comments, please write them into the comment section. Thank you for listening our class and please share this information with your friends also. Thank you.